Hi, I'm Dr. Neecey Hudson, Chair of Hood Medicine Initiative. Thank you for joining us for our Hood Med Chat series. Tonight is Do No Harm, Restoring Black People's Trust in the Medical System. A chat with Jennifer Johnson-Muhammad, genetic counselor and health advocate. So thank you for joining us.
Thank you.
We also have Jonathan White, who is the policy chair for Hood Medicine Initiative. And both of these lovely people were two of my best friends at MIT. And so we're gonna have a little nerd chat tonight to just go over, some of the history of medical abuse and human rights abuses against African Americans in America, and how that sort of influences the mistrust of the medical system that we see among the Black community today, and how that's influencing their reticence to get the coronavirus vaccine. So Jennifer actually did her master's thesis on this topic. So I'm gonna go ahead and start with sort of asking you to talk a little bit about setting the stage for our listeners, to let them know like just how ancient this this mistrust is, because a lot of people kind of like they can sort of point towards the Tuskegee experiments and HIV and how that was handled in the Black community in the 80s and things like that, but it actually goes all the way back to 1619 and across the entire diaspora where African slaves were shipped. There is a legacy of medical experimentation. We were lab rats for centuries. So Jennifer, if you don't mind like kind of giving us a little bit of background to jump off with.
So actually I like that you're starting off with 1619 because I do have that New York Times magazine upstairs actually, which was riveting. Anyone who hasn't read it, I suggest you try to get a copy of it. But so I have two, well, just to give you a little bit of my background, of course, for those of you who don't know, I know Dr. Hudson and Jonathan White. We all went to MIT together. I have a bachelor's degree in biology, but I have a double master's in health advocacy and human genetics from Sarah Lawrence. And in terms of my health advocacy degree, we did have to take classes such as health policy, and the history of healthcare. And I think starting off with 1619 is a very good jumping off point, because one of the articles that we did have to study in my health advocacy program, and I do want to just thank thank Marcia Hurst, the director of the program, who I did try to do an excellent job of trying to pull in different cultural standpoints to the curriculum. But she did give us articles about the black slave women, and how the quote unquote father of gynecology, that doctor, was using black slave women to do medical experiments. And if you know a little bit about those experiments, of course, there was absolutely no consent given. There was no anesthesia in terms of the procedures he was doing. And the part of what he was trying to accomplish in terms of why he's doing these surgeries was there was a medical, I guess, thought process at the time that Black people had a higher tolerance for pain.
At that time, or we'll get there. We'll get there. Go ahead.
We'll get there. But some of well, we're gonna go there and come back. So, but some of the thought process was that Black people had a higher tolerance for pain, and that was why it was deemed as more acceptable to do these types of studies on these slave women, because their attitude was, well, they're not even feeling it, like they're not feeling it the way a white woman would feel it. And so it really started way before COVID, way before all the things that we're hearing now. But I did want to tie in my thesis a little bit, because part of my kind of just personal interest in terms of my career has been just making the Black community aware of sickle cell disease and sickle cell advocacy, because for a number of reasons, the advocacy for sickle cell disease just isn't where it should be. And for those of you who don't know what sickle cell disease is, it is a genetic disease that affects red blood cells, and it is seen with an increased frequency in people of African descent. I did my thesis on the history of advocacy and sickle cell disease, and to just kind of speed the conversation along, in my research, I found out that in 1972, there was an attempt to create the National Sickle Cell Disease Act, and it was going to be a large-scale policy act that was designed at improving advocacy, and along with the advocacy, it would improve testing, right? Because if you have sickle cell trait, you won't have, 9 times out of 10, you have absolutely no symptoms. You don't know that you have it. And there are even some people with mild sickle cell disease who don't know they have it. And I've seen that too. So part of the goal was to incorporate this program and add the advocacy and the education. And they were attempting to pass this act in 1972, but it started to get some traction, but then the traction came to a full stop when the story broke about the Tuskegee syphilis experiment. And so any headway that I think the government could have made in terms of the act stopped because this story just broke about an experiment that government doctors knew about. And so at that point, I think whatever little bit of trust there could have been formulated, or I should say created, because there was already distrust. I think any steps that could have been taken really just stopped there. And I think that it really continues to affect our attitudes in terms of medicine. I used to also do HIV advocacy, and there were a lot of, in the community of color, that was also not easy to advocate because there were conspiracy theories and mistrust going there. And we're seeing all this continue with COVID. So it really is historical. It's not new. I just think that we are going to have to, as a community, kind of find new ways to bridge the gap and kind of build more bridges in terms of, our trust of the government and the medical community. But I think in some ways, I'm hopeful. I try to stay optimistic because I'm a mother. I think that we're at a good time. We're at a good time because I think that, with the deaths of George Floyd and Breonna Taylor, I think we're getting a much more receptive audience historically than we've had in the past. So I think that's important.
Yeah. I think it's hard.
Jennifer, you mentioned some words. I'm sorry. Well, you mentioned some words that I think are going to come up in this discussion and play an important role. And it's one of the things that I think most of the people in our community don't fully understand, and why there's such a roadblock between their interpretation of the Tuskegee experiments and how they view medical care in general, right? You mentioned the word consent, right? And that was something that was completely absent in the Tuskegee experiment. And most people don't understand that the lack of consent is why that quote unquote experiment went so horribly wrong. Not just the lack of consent, but the lack of proper explanation and understanding about what those men were being involved in is not something that's been replicated in much of the science that we see today. And I think that's one of the hurdles that we have to get over before we can get people to understand that this vaccine and the medical care that people are getting today, while it has numerous racial disparity issues involved in it, it's not the same as the Tuskegee experiments in any way, shape, or form.
Thank you for making that
and
point.
I'm really glad that you said that, Jonathan, because I think that a lot of people don't necessarily also even know what the Tuskegee syphilis experiment was. And I know myself and Sheldon, I know you guys remember Sheldon from MIT, from MIT, but I was on his feed, and he and I had to actually kind of explain the experiment to someone, because there was someone on his feed saying, oh, but they gave those men syphilis.
Why don't you go over it really quickly for our listeners?
Right. Okay. So I think, I want to piggyback on Jonathan's point, because I think what he said is important. I think that you're right. I mean, we do have to talk about consent and lack of consent, but but one thing that I do hear commonly that I think that is important for me to bring up is that I think there's a lot of people who think that the men in the Tuskegee syphilis experiment were being given syphilis, and that's really not what happened. These were men who had syphilis, but the issue is that, well, there's several issues. The first issue, there's several. So the first issue, and this goes a little bit to what Jonathan was saying, it wasn't even so much, it was consent, but it was also just a lack of being given the correct medical information, because they were never told, you have syphilis. Syphilis is a sexually transmitted disease. You can pass it to your partner. Your partner, if she's pregnant, can have a child with congenital syphilis. Congenital syphilis can cause neurological symptoms in the baby. I mean, these are all things that needed to go into just the counseling, the care of the patient, and patients or research subjects, I mean, whatever you want to call them. This is basic information that they were not given. And when the study initially started, there wasn't penicillin, so there wasn't treatment at first. But I think what became so egregious about the study is that when it was discovered that penicillin was a very effective treatment for syphilis, treatment was withheld. And so you know, it's not even, so it's partly that they were
but not just withheld. It was withheld so that they could continue to study how syphilis affects the body when you have fulminant disease. So they let these people continue to deteriorate so that they could collect data on what that looks like.
And these men, as far as I understand, these men were under the impression that they were being treated with the appropriate medications for their disease.
But they were not.
Right. And I wanted to get back, I wanted to also add that there was, I don't know if you guys know about this part, but there was actually like a list. Like these men's name was on a list, and the list was distributed to hospitals, and like the hospitals are basically told, if this person shows like they're on the list, and that's you know what they're being told. So it was very it was large scale. You know, it was large scale, and it's you know, so there's, like I said, there's so many things that just went wrong.
I didn't think that there was more rage in that well, but it just like whoosh. I didn't think it was more in there.
And you know, and I think the other and you know, I think the other thing that I found out when in terms of studying my thesis that I did not know is that the original studies, that the Tuskegee study was based on a Swedish study. So there was actually a Swedish study being done even before it came to America, similar thesis. Let's see how you know, untreated syphilis, let's see what it does to the body. So it's very interesting, because I think that the scientists who did the Tuskegee experiment, I think they, in their mind, they were thinking, oh, well, there's already a European study going on. Let's bring this study to America. But obviously there's a lot of racial dynamics involved in what they did that weren't there, you know, in the Swedish.
And the other difference is that you have to think about it in terms of like how Black lives are regarded, right? This is the issue of our era, but it's not just the issue of our era, it's the issue of human existence. You know what I mean? And ever since slavery, You know, I mean, even here, like medical schools, the Lancet published an article about the history of medical abuses. And here there are medical schools that basically relied on enslaved Black bodies as anatomical material. And then they recruited students to come to their medical school in the South, because there's so many slaves to experiment on and to practice your surgery and everything else. So you have to think about even the evolution of modern medicine. You know what I mean? Like, this is where it started, was experimenting, unethical human experimentation
and
on
so
us.
One
And
thing
yeah, go ahead, sorry.
One thing that's interesting around this time, right? Because the experiment started in what, 1932, right? And
I can tell you, keep going.
If my memory serves me correctly, Birth of a Nation is, you know, is one of the films around that time. Essentially, there's this idea that sexual promiscuity is a moral issue with Black people, right? And so one can imagine
I gotta interject. Even though we were the ones that were raped and used
and exploited
and sodomized and used as sexual frivolous toys for centuries. Continue, please.
So one can imagine that when you see a patient who presents with syphilis, that as a medical professional, you can look, a Black patient, sorry, that presents with syphilis, and knowing what society tells you about Black people and their promiscuity in that day, you can look at them as less than because they deserve to have syphilis, since they're these sexually promiscuous and immoral or amoral people who don't know how to control themselves.
Yeah.
You know, so there's so many layers that play into why these Black people were treated in this way that most people wouldn't understand unless they understand the context of Blackness in the early 20th century.
I'm sorry, in the early 17th century?
Well, sorry. Yeah, let's starting from the early 17th century and proceeding into the 21st century.
And not just here, let's make it clear, not just here, but like I said, across the entire diaspora. There's so many stories from the Caribbean of people being experimented on as well. And it was just par for the course. Yeah.
I just wanted to interject. I wanted to, I found the appendix to my thesis. I just wanted to share something. And of course, you know, this is me reading from my references. I don't want to take credit for this, but this is what I wrote. The Tuskegee syphilis study remains as the longest non-therapeutic study on humans in history. The study, which was initially intended to last for only 6 to 9 months, resulted in a 40-year-long experiment that was eventually ended when a public health service employee went public with the story of the study in 1972. A number of state and local agencies, the United States Public Health Service, Tuskegee Institute, and community members collaborated to keep the study in Macon County, Alabama, continued until its end. In the early days of the study, and I'm not going to read the whole thing, I wanted to just, in 1929, the Julius Rosenwald Fund granted the USPHS, the United States Public Health Service, funds to conduct epidemiological studies on syphilis in African Americans of the South. Of the 6 counties investigated, Macon County, Alabama, home of Tuskegee Institute, was found to have the highest incident of syphilis. So they did not, so that's kind of where it started. So Jonathan, you were right with you said 1932. And in 1932, Dr. Taliaferro Clark, chief of the USPHS Venereal Disease Division, presented the option of observing the high syphilitic population of Macon County. Most of the syphilitic African Americans in Macon County went untreated, and hence he felt that observing the effects of untreated syphilis on this population would be important scientific research.
Yep.
So I just wanted to add
and you know, I want to, although I'm sure we're going to get into this even in more depth, the reason we talk about Tuskegee is because it's quite understandable to us, and it should be to most people, for why Black people have a reluctance to trust and believe in medical professionals and medical therapies, because we have been through a history, as both Neecey and you, Jennifer, has said, of being taken advantage by the medical community. And when we're not being taken advantage by the medical community, we're being dismissed by the medical community for serious ailments that we've suffered from. So we understand, the three nerds that are here on this conference call understand why there is a reluctance amongst Black people to take a vaccine that's being said will cure you, or not cure you, but assist you in saving your life, right? The reluctance is understandable, but there's so much more that we have to talk about and so much more we have to get into that people have to take into account before making a decision to not take something that may be life-saving to you, but also life-saving to the people that look like you.
Yeah. Right. And I just want to, I hate to beat a dead horse, but I have to read this paragraph because I think it's important. This is still from my thesis, but this needs to be read. So the difference between the justification for the Oslo study and the Tuskegee study were the medical community's attitudes regarding African Americans' health, intelligence, and sexual behavior. The medical community believed that African Americans were promiscuous, which attributed to the high rates of syphilis, and that they were indifferent to treatment, i.e. they would not have sought treatment regardless. In fact, it was believed that, and this is in quotes, syphilis in the Negro is in many respects almost a different disease from syphilis in the white.
I think they think that about a lot of things, especially.
Well, I just thought that paragraph was important for you to hear, Dr. Hudson.
Absolutely.
Yeah.
Absolutely.
Because I think it ties into what it
does. Yeah.
I think it tied into what Jonathan was saying earlier also, because I think that, of course, there's the stereotypes that Black women are promiscuous. There's the thought process that, that Black men are rapists. They're always out to just have sex with everybody and anybody. And that was the thought process. And that thought process continued over into doing this study. And I think that that's important to bring up, is that people, or we're fighting against centuries of thoughts and baggage of us as a people. And that's affecting everything.
And when, again, when, as we know, physicians take their biases and their presumptions and their prejudices against people into the exam rooms, into the clinic, that's what you get. And that's why we still are where we are, because the overall worth of Black lives has not gone up since the 17th century. You know what I mean? So it may be getting cheaper. So at least then they had to auction, you know what I mean? But now it's people just, I don't think people even have a sense of like when you talk about the Tuskegee experiments and, try to offer some rationale for those monsters and thinking that, I'm sure that was their scientific method or whatever, but we need to harken back, and remember that all along throughout the entire development of modern medicine, they would use our bodies just to kind of display. It didn't have to be a medical reason. It didn't have to be a scientific purpose. They would just cut us open just to display our skin, our organs, our genitals, you know what I mean? So, almost like wholesale taxidermy. So it's not just about that at the time there were antiquated notions of ethics in research. It's also about the fact that they did not value our lives, still don't.
Yes.
And then we were merely lab rats. What does it say? Anatomical material. Okay. So let's keep it in perspective, because that anatomical material was at the dawn of medicine. You feel me? And they built their whole foundation on that. And now we come into this modern age. There should be no wonder why we're still not getting treated you know, with palliative care, when we need pain medicine, there shouldn't be no wonder why there's such huge disparities in maternity care and such huge death rates with Black mothers and Black babies. None of that should be like a mystery after tonight, I would hope, because what I'm hoping that everyone is connecting is how the history of all of this violence against us, because that is what it is. You can call it medicine or a study or science or whatever, it's violence, okay? Because we're not even talking about consent here. So, and that same thing continues into today. And that's a huge reason why people don't trust doctors.
Yeah.
So, yeah,
you know,
please.
Again, in talking about Tuskegee, people need to understand that we understand what Tuskegee means to people, but that people need to have a better understanding of what Tuskegee really was.
Mm-hmm.
And the reason you have to have an idea of what Tuskegee really was is because we need to understand that what we have today is not Tuskegee, right? What we have today because of Tuskegee, and you said a very important word, Dr. Hudson, you said ethics, right? Because of Tuskegee, we have a bioethics commission, right?
Mm-hmm.
And so, and the, you know, what happened with Tuskegee was related inextricably to how society viewed Black people, inextricably. Mm-hmm. Everything that's happened to Black people in medicine up until Tuskegee ended was inextricably tied to society's view of Black people, right? So the question is, does society view Black people differently today than it did in 1932? Not very much, right? The answer is not very much. But what has changed, right? So what has changed that we can say to Black people that this is not Tuskegee and Tuskegee won't happen with this vaccination? I think the only thing that we can point to changing is the way in which science itself is reviewed and the way in which these things are made public, right? Because you made a point earlier, Dr. Hudson, about physicians taking their biases into a patient room, right? You know, doctors and patients are like Vegas. What happens in the doctor's room stays in the doctor's room, right? You know, when you see a doctor, unless the doctor has done some form of malpractice, whatever advice they give you, you pretty much take at face value, unless you want to get a second opinion. And that doctor doesn't have to necessarily review his treatment plan or his advice to you with someone else, unless it's a serious issue or unless something goes wrong. But with scientists, you can't get away with it.
People are protected by HIPAA. I just want to throw that out there, not to interrupt you.
But with scientists and with
I think he's talking more so in terms of there is no oversight there. Do you know what I mean?
Yes,
like
exactly.
You go to your physician, they can treat you however they want to treat you. Please
right. Okay.
Sorry.
Okay. Fair
they
enough.
Can give you what they believe is true. In case in point, let's look at Serena Williams, for example, right? She's on the birthing table, giving birth to a child, one of the most momentous moments in any woman's lifetime, giving birth to a child, and she almost dies, right? She almost dies because there is a problem with her health. She is aware of this problem. She knows what the issue is. She's telling physicians, hey, I have a problem. It's presenting itself right now. I need you to do something about it. And she's being told, chill, I got this. I know what's going on. You don't know anything. We got this. Meanwhile, she's set to die on the table, right? And unless she advocates for herself to the level that she did, we probably don't have Serena Williams as the greatest athlete of all time anymore, right? She probably dies on that table because physicians believe what they believe and they take that into the room. And unless there's somebody in that room who's going to challenge them about their belief, whatever they say goes, right? So unless you're challenging them yourself as a patient, unless you have a health advocate in the room with you challenging them, or unless another doctor is aware of what they're saying, whatever that physician says is what goes for your health care. The same is not necessarily true with scientific experimentation, because scientific experimentation, if it's to be legitimate, must be peer reviewed. right? And that's something that has changed dramatically over the last century of time.
Mm-hmm.
Not only peer reviewed, but the thing is there's oversight at every step of the process. Every last test tube, every petri dish, everything is accounted for. Every lab notebook, everything that you want to do, you have to propose in detail, and then someone has to review it, decide maybe they'll give you the money for it. Then you have to continue to and then you got to keep them records like tax records. You feel me? Like, you can be audited at any time. Your grant money can be snatched anytime. You can't cheat. You can't lie. You can't make stuff up. That's the end of your career, period. You know what I mean? And that's the most important distinction that we can make in this moment, because what we're trying to say, which is an absurdity, I know, but like what we're trying to say is, we understand everything that you feel, but could you please just overlook that just one time? Because what's going on right now is bigger than that. Because if you take everything that we say have already shared and everything that we're going to share, you know, into account, then what that means that now is that we should be more careful than anyone out here with COVID. Because if we end up in the hospital with COVID, they're already making questionable, different decisions about who lives or dies because of the bed shortage. You know what I'm saying? And there's like, for example, here in Indianapolis, there was a woman, Dr. Susan Moore. She went to IU North Hospital, and she had COVID, and she documented her lack of care on social media, and ultimately died after being refused pain medicine, CT scans, everything that you would think one would do for a COVID patient. And we do have a video clip of that, so we're gonna play that now.
This is the second worst day here at IU North. Yesterday, a Dr. Bannock, Bannec, wanted to send me home. You know, at that time, I'd only received 2 treatments of the remdesivir. He said, you don't need it. You're not even short of breath. I said, yes, I am. Then he went on to say, you don't qualify. I must have, because I've gotten 2 treatments. And then he further stated, you should just go home right now. And I don't feel comfortable giving you any more narcotics. I was in so much pain from my neck. My neck hurt so bad. I was crushed. He made me feel like I was a drug addict. And he knew I was a physician. I don't take narcotics. I was hurting. So, spoke to patient advocate who left me wanting. There's not much I can do. So I started asking, send me to another hospital where they can treat me. And if they're not going to treat me here properly, send me to another hospital. Well, next thing I know, I'm getting a stat CT of my neck with and without contrast. The CT went down a little bit into my lungs, and you could see new pulmonary infiltrates, new lymphadenopathy all throughout my neck. And all of a sudden, yes, we'll treat your pain. You have to show proof that you have something wrong with you. in order for you to get the medicine. I put forward and I maintain, if I was white, I wouldn't have to go through that. And that man never came back and apologized. This Dr. Bannock guy. And then today now, supposed to be getting the narcotics, right? They came in 9 o'clock. I've been in pain since 7. And when they came in, very, very sympathetic. Yeah, we will get you pain medicine. I don't want to give you IV narcotics. How about PO? Fine. I just want my pain to end. So then he says, well, what pain medicine? I said, I don't know. I don't take them on a regular basis. I don't even write for them. All I know is that I'm in intense pain and morphine worked. Okay, well, we'll give you Percocet. Okay? I don't know nothing about it. I don't think I've ever had it. It was another 2.5 hours before I got the pain medicine. The nurse came in. The first thing I said to that nurse was, why did I have to wait for so long? The nurse snapped back. Well, you're not my only patient. I have 5 other patients, you know. I said, I have been in pain since 7 a.m., you know. Well, I can't be in here every 5 minutes. I said, no, you were in here once in 4 hours. What? I was in here 1.5 to 2 hours ago. That was once, since your shift started at 7. Well, I had other people, and I had to take the shift change. We had to give report. I am a patient. Are you going to take care of me or not? And he went in. Now, that is not how you treat patients. Period. So I don't trust this hospital, and I'm asking to be transferred. These people wanted to send me home with new pulmonary infiltrates and all kind of lymphadenopathy in my neck. The other thing that white Dr. Bannock said was that if I stayed, that he would send me home Saturday at 10 p.m. in the dark. Who does that? On a week, who does that? And that nurse was telling me, oh, I was marching in Black Lives Matter. I told him, no, I don't believe none of that. Not one bit, not one iota. He wouldn't even know how to march. Probably can't even spell it. This is how black people get killed. When you send them home and they don't know how to fight for themselves. I had to talk to somebody, maybe the media, somebody, to let people know how I'm being treated up in this place. And he gladly told me, I know you're a doctor. So he didn't want the black doctor to have no medicine, nothing. And then had the nerve to say it's because of him, the nurse, that I got the medicine. Really? Because of you? No. How about because I had that stat CT in my neck where it showed all of that lymphadenopathy and infiltrates? Yeah, you didn't know about that? You didn't get that in report? That's what I said. To being black up in here, this is what happens.
So basically that was her documenting what she went through in the hospital. And then just today, I believe the hospital responded. And so in a press release, basically the hospital is intimating that perhaps the nursing team was intimidated because she was so vocal about her mistreatment. And maybe that's, you know, with everything going on with COVID and everyone being so stressed out, maybe they were just intimidated by this big Black woman who was dying in the bed, can barely breathe, and was in terrible pain. And they were just so scared of her that they left her to die. Okay. But here's what I want you to know about that hospital. Not only is my best friend have on her medical directive and, you know, sort of on her person that if something happens to her, never take her there. But I had to leave my OBGYN in that hospital because couple stories. Actually, there's more than one story. So there was the anesthesiologist when I was giving birth to my second child in that hospital. And, you know, I had gone a long time. I wanted to try it natural again. It wasn't working. They were stuck. He was stuck, whatever. And then I had been in labor for maybe 14 hours at least. And they were just like, well, the anesthesiologist is getting ready to go home. So last chance. And I was just like, cool, send him in. So he comes in and he starts prepping my back, and I'm telling him, I've never done this before, right? And so I start telling him that, like, you know, I fractured my spine at L5 when I was thrown from a horse, which is basically the, you know, biggest issue of my life and why I'm going through medical disability now. And, you know, it's different now, you know, it's slightly crooked if you see it on an x-ray. And I tried to explain this to him. I even named L5. Who the fuck names L5, you know, in the room? Nobody was in there with me. It was just him and me. And so he completely disregards that. He doesn't care. So he just starts stabbing me everywhere. He can't find it. He can't find the space. And I'm like, at this point, I'm crying, right? But silently, he doesn't know I'm crying yet. And so then eventually he pokes me and leaks cerebral spinal fluid. And I don't know if anyone, has this ever happened to anyone? You get the most blinding headache, okay, that lasts maybe like 5-10 minutes. It's just blinding. And so I kind of screamed, and then I just started crying. You know what I mean? And he was just like, oh, your spine is weird. It's not normal. And then he looks at me and he was just like, why are you crying? Like, he was mad at me because I was crying. And then he walked off in a huff and just left me there. And then after this had all happened, because I had my I conceived my second child because I was having ovarian cysts. And she was like, I'm gonna give you one last chance. You wanna do it, you better take it, because I'm taking everything out. I was like, cool, sounds good, I'm tired of it. But for my own reasons, we did it kind of piecemeal along the way because she was trying to preserve my fertility until she couldn't. And so because I had like maybe 9 surgeries successively to remove cysts or to remove an ovary or this or that, whatever, there was undissolved suture in my peritoneal cavity. And it got to the point, I think I might show a picture of this as well, but there got to the point where my entire belly button looked like the alien was about to come out of it. Like there was pus leaking out of my belly button. You feel me? Completely septic. So I go into the office, but she's not there. And she was on vacation. They kept ignoring me. I kept calling. They're like, well, he doesn't think you should come in, so blah, blah, blah. Finally, I just went in, no appointment. I just went in, acted a donkey probably, but not really, because like my stomach, wait till I show the picture. I wish I had it with me on the clip. But like, so he's so rude to me in the room and essentially does nothing for me, sends me home, says I'm gonna send you to a specialist or whatever. I needed surgery, once again. And then I had to then go elsewhere and get it. And then when she found out everything that had happened and how he treated me in the exam room, I told her, I'm leaving your practice, obviously. He refused to apologize. She called me at 10 o'clock at night crying, my doctor, who delivered both my babies, okay? Because he refused to apologize and I was leaving the practice and I left. And honestly, I never filed a complaint. Now that all of this is happening, I'm gonna urge everyone out there to file complaints. I just figured out how to do it this week. I'm gonna go back and retroactively file complaints about everything that I've been through, especially at that hospital after what happened to Dr. Susan Moore. And I would encourage everyone to do that because at the end of the day, these are the things that inform our mistrust. And it's unfortunate that we are seen as
expendable.
Expendable, but it's like, if you think about it, we were beasts of burden for centuries. If you think about the way that we handle veterinary care, I'm not saying it's perfectly, on the level, but there's a difference in the way that we treat animals versus humans and the way their lives are expendable, the lengths we'll go to preserve their life, whether or not we'll give them adequate pain control. As in my skin, I've seen dogs treated better than me. You know what I mean?
Yeah.
Like there was, and so I won't get into too much more because I don't want to angry cry through this video, but that story really got to me this week because that could have been me and 2 other Black women I know that live in this city who almost died at that hospital. Yeah. You know what I mean? And it's absurd, but that's the way they do us. So you should be even more hesitant to go to that party, to take that mask off, to, you should be even more eager to get in that vaccination line because you end up in the hospital with COVID. Please, we already know what kind of care we get. That's the last thing you should want.
Yeah. I mean, there's a reason why the incidence of death and the incidence of adverse reactions to this virus are so much higher in our communities than in other communities, right? Yeah. All of the health choices, all of the health disparities that we've accumulated over decades, if not centuries, has played out in public because of this virus. All the comorbidities that we suffer from all are affected by this virus, right? And so that point that you made is one I don't think many people are talking about. If you can avoid having to show up in an ER as a Black person or a medical professional's office as a Black person, you want to avoid having to do that because you don't know whether or not you're going to get adequate treatment for this disease, for this virus. You just can't be sure.
Straight up. This woman was a physician. She like me communicated to them. Jennifer, what were you saying about what she had and how she?
Oh, so the article that I read said that she had a diagnosis of sarcoidosis, which is an autoimmune condition. And in her particular case, unless I read the article wrong, in her particular case, it seemed to be affecting her lungs. And we all know that that's the organ that COVID goes for, is the lungs. There's no debate about that. And so I think, in her particular case, she was advocating not just for herself as a COVID patient, but also as a COVID patient who, had this underlying condition. So, there were kind of 2 things going on that she had to advocate for. And I wanted to, again, piggyback on something that Jonathan brought up because he was bringing up the comorbidities. And it's I think something we have to understand is that whatever happens to the population at large, whatever happens in the white community, it happens in our community worse, right? So our rates of diabetes are higher, our rates of heart disease are higher, our rates of obesity are higher, and there's a lot of different reasons for that. Some of the reasons that I personally see as a health practitioner is I see people who are and underinsured. So they're not going to the doctor. you know, and something that I always tell patients is, look, hypertension is the silent killer. Most cases of hypertension, you have no symptoms. And so then if you go, and so you don't know you have these things. And so it's almost like a perfect storm when you get COVID. And I think that is part of why we do need to really take COVID seriously, because there's some of us walking around who we don't even have a good baseline. We're not doing what we need to do in terms of preventative care for a number of reasons. There are some people who, like I said, they're un and underinsured. They can't
don't have access to nutritional health.
They don't have access to nutrition.
Yeah.
So some of it isn't, some of it is factors that are somewhat beyond their control. But I also have to say, as a healthcare practitioner, I see the other end also, and that's not good either. And the other end is people who have the insurance, have the money, have access to healthcare, but don't go to the doctor because they don't like doctors. And again, these are things that are said to me as a healthcare practitioner. I don't like doctors and I'm going to pray on it. And so you have people who just, it's the mental barrier. It's not even the other barriers. It's the mental barrier that's preventing them from getting the care they need. And then, like Jonathan said, you get these, you go to the doctor, and then God knows what's going to happen when you get there. So it's really almost cyclical.
Yeah.
And there's two other things that play into this, right? We most of us have a friend or a family member who we believe went into the hospital for something very, very simple and didn't come out, right? And so that triggers a lot of fear on our parts that Black people go into the hospital and don't come out, or if they come out worse, right? But another part that plays into this is some of us don't go to the hospital until it's too late, right? And so, as you said, Jennifer, there are so many of us who are walking around with all these ailments that we have no idea we have, who have hypertension or heart disease and don't know about it. And the only time we find out about it is the 11th hour. And so our family doesn't know anything's wrong. Nobody understands what's going on. We go into the hospital and we're literally in the hospital on our last leg. And for some of us, we don't make it out. But the perspective of our family members, the people who love us, is, oh, they were fine yesterday. They went to the hospital and they didn't come back home. Right. And so we understand why there's this reluctance to deal with medical professionals. Okay, let's try not to have to deal with medical professionals. Let's get this vaccine so you don't get COVID. You don't get sick. You don't have to interface with medical professionals because of COVID affecting your body.
For sure.
And I also just have to say this again, as a medical practitioner, let's do the preventative care, right? Let's try to do what we need to do, you know, so that we don't even get to that point. You know,
and I had an interesting discussion with a woman on Facebook today, because she was telling people, hey, listen, take your vitamin D, do your exercise, boost up your immune system. Don't worry. And she didn't say this explicitly, but essentially she was saying, do these things instead of taking the vaccine. And I said, listen,
absurd.
All those things you say are accurate. We need to do everything we possibly can to boost our immune system, to take care of our bodies, to increase our health, right? That's just something, absent COVID, that's something we should be doing. But all of that stuff can only assist with what happens to you when you get COVID. It can't prevent you from getting COVID. And once you get COVID, it can't prevent all of the negative things that COVID can do to your body. So the best thing we can do is to do all those things you suggest, but also get vaccinated so that if you happen to get COVID, it reduces the likelihood that you will suffer from the worst adverse effects of that virus.
And let's be clear, there's a lot of adverse effects to all of your organ systems, and they're lasting. Some of them are permanent, you know, and like you were saying, Jonathan, like a lot of us don't know that we're walking around pre-diabetic, you know, having all these like silent symptoms, like Jennifer was saying, but COVID will catch you out. Like you said, COVID will catch you right out. And then you'll realize that your heart muscle is weak and everything else real quick. Sorry, Jennifer, what were you gonna say?
And I just want to add just like a personal story, of mine. I have always had to get the flu shot. It really kind of hasn't been an option per se, but I've always worked in hospitals and they've always been very, strict about it in terms of if you're going to work in the hospital, we need to see proof of your flu shot or you have to wear a mask. And I always got my flu shot. And it's very funny because, in 2018, I actually got the flu, right? And I have to tell you both, it was in the grand scheme of what the flu can be, right? Because we know people can die of the flu. In terms of what the flu could have been, it was a mild case. The reason, and not to make the story longer than it needs to be, I had a mild fever and it started to resolve, but just because I'm in good health, I think, and because I know my body, I knew there was something wrong when the fever came back. Because I know when I'm sick, I get a fever, I sleep it off, and then I'm good. It came back, and I said to my husband, I was like, I kind of don't feel right. So I went and I went to the Minute Clinic. They gave me the flu test, and I had the flu. And I remember the nurse practitioner saying to me, like you came in here on your own, right? Like you drove yourself here, like you're telling me your symptoms, But she said, you are in a fairly positive state because you got your flu shot. You had some protection. We never guarantee that the flu shot is 100%, but she said, look, like you're going to sleep this off and be fine. And we gave you some Tamiflu. And I was fine. But I think that story is important because I want people to understand that, no vaccine is 100%, but you want that protection. I would have been much worse had I not had my flu shot. And I agree, you can't always compare everything, but I just want people to understand, as Jonathan said, why it's important,
No, I think that's a perfect point because it's like what people probably don't understand about vaccines is that, the point of them in general is to introduce your body to the pathogen so that it remembers it for next time and starts to be able to produce the antibodies against it, so that you have immune protection. And if you don't have, for us, we've never been exposed to COVID before. It's novel. So none of us have, any immunity. So that vaccine is the least that we could do at this point. Like, that is how we'll be able to start to build.
So there's two
immunity.
things that I wanted to, there's two things. One is, and I apologize if I'm having internet issues. I keep getting it.
Well, we can hear you, Jonathan.
Oh yeah, you're kind of frozen now.
One is that Jennifer said two things, and you touched on one of them, Dr. Hudson. Knowing your body, right? A lot of us don't do enough to understand our bodies and how they react to illness and whatnot. We don't know enough about how we respond to different things, right? So you have to know your body. And the second thing is understanding what a vaccine really is. And I'm glad you started touching on that, Dr. Hudson. And I think we should delve into that a little bit. Maybe you and Jennifer can talk about that.
Yeah.
What a vaccine is, what a typical vaccine does, and how the COVID vaccines are slightly different from what we would typically consider a vaccine.
Well, I think we should start with talking a little bit about coronavirus. Just because it's, it kind of plays into how they design the vaccine, but essentially like a lot of viruses, it's just, either like a little piece of DNA or a piece of RNA encased in a protein. And the coronavirus in particular is an RNA virus. It's encased in protein envelope as well, but it's got those spikes on the outside that we keep hearing about. And those are the spikes. Those are the part of the virus that helps it sneak into our cells. And so what they realized from having, worked on coronavirus with SARS and just advancing a lot of our knowledge over the past couple decades, is that that contributes in a big way to your immunity, because your cells that go attack viruses and foreign pathogens, as well as the cells that remember what they look like and keeps a record for next time, both of those recognize that spike protein as like the carrying card for that virus, right? So if you think about it like in terms of like a Bond movie, and if your immune hub and then lymph nodes was MI6, then your B cells, which are like memory cells, they're the nerds sitting at the computer, like doing all the hacking and sending out like everybody's missions and giving them all the information that they need. Here's this terrorist, go fight that. Here's his whole MO. Here's his dossier. That's what the memory cells are, right? And then you got Bond and all his homies, the T cells, you know what I mean? And so they get information from the system, from the other cells, and they're like, okay, so I need to go do that. Bet, send me the specs, we got it. So all of that happens because they are able to recognize different pieces of different things, whether it's a bacteria or a virus or a parasite. Different pieces of those pathogens are able to be recognized by your immune system so that they can remember the next time they see you, produce some, like that's the point of antibody production. They like kind of like remember that whole thing goes into the library. And so what's cool about the new COVID vaccines is that they are messenger RNA or mRNA vaccines. And so essentially, they are just delivering a little cheat code to your cell to produce that spike protein. And so that's sort of like an artificial way for you to let the MI6 hub know what's going on, instead of being exposed to it. So essentially you'll get like a shot in the arm, right? And your muscle cells will be the ones that get the cheat code. And then they will produce the little piece of the protein, and then they'll have a huge party and invite everybody. And then they'll stand on top of the cell and be like, guys, you see this? This is what we need to pay attention to next time. This is COVID. I know it's new. None of y'all know COVID, but it's new. This is what it is. Go put it in the library. And then next time you see it, we'll be able to fight it better. And everybody's like, cool. And that's how it kind of happens. And what's important about the way the vaccine works is that, viruses, because they only have that sort of protein shell encasing their DNA product, their genetic product, whether it's DNA or RNA. The whole point of them wanting to get inside of your cells is so that they can hijack your cell to make the proteins that it needs to make more virus particles. So essentially, like in the cells that the virus infects, it's kind of like, okay, give me your copy machine. I'm gonna make my own copies. And that's part of the way that the immune system is able to recognize when a cell has been infiltrated, because they'll able to see that there are these proteins popping up, and they're like, I think that cell's been infiltrated, so we better go take care of it. And so, so in the way that the vaccine works is that instead of the virus itself, coming inside your cell and telling it to make virus particles, and then your immune system noticing that they're there, the vaccine cuts that whole process out and gives you the cheat code to make that protein and tell your immune system. And that's sort of a way to elicit that immune response and start to build antibody production and immunity over time. They're saying with the 2 doses that there'll be lasting immunity. Maybe like, I think there's a new study that said might be like 8 months we're looking at, which is about what we see for the flu. So it could be, just one of those things where it's like a flu season, but I don't want to give the impression that even though it shares a lot of commonalities with other viruses, we don't know as much as we'd like to know for how much y'all be hanging out in the streets about what the long-term serious health effects are.
And Dr. Hudson, oh, sorry, go ahead.
Well, I just wanted to say that one thing that I think is important to say is that the flu shot and the COVID vaccine are not the same thing.
No. Oh, so, yeah. Sorry. So that part. Yeah. So a
right. And I
vaccine. Yeah.
I just want to be clear on that because I don't want there to be confusion about that. Just because you've had your flu shot does not mean that you're protected against COVID, and it doesn't mean that you shouldn't get the COVID vaccine because they're not the same thing. And I just want to make sure people are not confused about that.
Certainly, a great point. And also to your earlier point about the fact that you can still take a vaccine and still be exposed because you won't stay at home and put your mask on to COVID. You could potentially, down the line, be exposed to it and even get COVID, like you were saying about how you could get the flu vaccine and still get the flu. But the point of vaccination is that even if you do get infected after you've been vaccinated, you will have, you will have induced the antibody production inside of your body that will help you fight it off after you've been vaccinated. That's the point of a vaccination. It's not to prevent disease. It's not a prophylactic necessarily. I mean, it is in a way, but it doesn't mean that you will never ever get the disease. It means that if you're exposed to it, you have a way to fight it off.
Yeah, and one of the things I think that we're trying to do here with Hood Medicine, right, is talk about these things in a way that people understand, right? So that you're not listening to medical jargon and, you talked about B cells and T cells, but you also talked about it in a way through bond that I think people could understand, right? People have to understand that, like you're saying, vaccines only increase the probability that your body will adequately respond to an infection to keep you from having adverse effects because of that infection. It's not a cure. It does not cure you. It does not prevent you from getting the disease. It does not prevent you from having a serious adverse reaction to an infection. It increases the probability that you won't, right? So let's think about like playing blackjack, right? You're playing blackjack. The dealer deals out cards. The dealer is showing a bus card. Let's say the dealer's showing a 5, right? And you're showing you have 11, right? Sorry, you have 10, and the dealer's showing a bus card. You're going to take a hit, and you may even double up that bet on that hit because more than likely, if you get that hit, it will be a card that will win you the hand, and that dealer will likely bust. But it's not a guarantee because you can take that hit on your 10 and end up with a 12 or a 13, and that dealer can be showing a 5, have a 6 underneath, and then get a 10 as a hit and win 21, right? So doing the right things.
Yeah.
In that situation where you're showing a 10, the dealer's showing a 5, the correct thing for you to do is to take a hit, and you should win that hand. Probably 75% of the time you're going to win that hand, but it's not guaranteed because you never know what the dealer is not showing, and you never know what his hit card is going to be. Vaccines are the same way. You can take the vaccine. It doesn't guarantee you're not going to get the virus. It doesn't guarantee you that you're not going to get an adverse reaction to the virus. There are some people who take the flu vaccine and have a very bad reaction to the flu vaccine. There are some people who take the flu vaccine and still get the flu. But chances are, if you take the vaccine, the chances of you getting an adverse reaction to these infections dramatically decreases. And that's all you're trying to do. All you're trying to do is give yourself the best potential outcome. That's all you're doing. You're not curing yourself.
Yeah.
You're not, and you're not curing yourself, and you're not wishing for the best. You're not trying to be on either side of the spectrum. You're trying to find yourself somewhere in the middle where chances of you not dying are greatly increased.
And you're protecting others. You're protecting others when you get the vaccine.
And Dr. Hudson, before you go, and I want to mention something else, right? Because you talked about how COVID-19 is a coronavirus, right?
Mm-hmm.
Most people don't understand that there are classifications and species of virus. Coronavirus is a type of virus, right?
Mm-hmm.
There are tons of coronaviruses out there. COVID-19 is a specific coronavirus. So when people talk about this vaccine, they're like, oh, they've only been studying, this thing for 8 months, and then they came up with a vaccine. Yes, that's true. We've only known about coronavirus since maybe December of last year, right? So we've only had a chance to study it for 8 to 12 months. But people have been studying other coronaviruses, including the SARS virus, for years. So the underlying understanding of this virus is already there. And all they're doing now is trying to understand the specifics of COVID-19 versus the other coronaviruses that have been out there. Because this is a novel coronavirus, not the general coronavirus that we've known about or we've seen in other cases.
And our bodies have adapted to some of the other coronaviruses, to your point, because they've been around a long time. It's this particular one, the COVID-19, it's that particular strain of the virus is the one that we're focusing on. But I just wanted to, I thought Jonathan's point was great, but I did want to just again emphasize, when you get the vaccine, another reason to get the vaccine is to protect others, because you have to remember, not everybody can get the vaccine. Me, in terms of, I'm a genetic counselor, so I see patients with genetic disorders, underlying genetic disorders, who they can't always get vaccinated depending on what their diagnosis is. And so, you have to think about how you're, protecting other people. So it's almost like if you have high risk family members who you're around, and you may be their caretaker. And in a lot of ways, the best way to protect them is for you to get your vaccine so that you're able to, do what you need to do in terms of taking care of them. And that's something else that I think, we have to think about, because there are going to be certain classes of people who are not going to be able to get vaccinated. From what I've heard, these vaccines are currently approved for, I believe it's 16 and up for the Moderna, but don't hold me to that. Yeah. But the point is
like
that
18 for Pfizer.
Something like that. Yeah. So, you have young children, babies who can't get vaccinated, although the data supports that the children seem to, recuperate and do well with this. And, a lot of them seem to do okay. But the point is they can't get it. And like I said, there may be high risk people who, they can't get it. So we have to think about what can we do to help.
I think, like, to Jonathan's point, in terms
of
of like
we
the
want to be
odds,
clear, right? No, we want to be clear, right? Because you get the vaccine, it doesn't necessarily mean that you can't get the virus and further infect somebody else, right? You can still infect somebody with the virus. But if you get the vaccine and get the virus, and you are somebody's health care provider, or you take care of old family members or children, you decrease the chance of you having to go into the hospital and spend time in a hospital bed, and there's nobody there to take care of your grandmother, nobody there to take care of your children, right? You have to do what you can to protect yourself so that you can be there for other people. And, I think something that both of you guys kind of touched on, polio was a huge issue in the early 20th century. It was a huge issue. I'm in a fraternity, Alpha Phi Fraternity Incorporated. We work with an organization called the March of Dimes. The March of Dimes got its name because of the effort they put in to getting people to funding the research for, and then getting people to sign up and take the polio vaccine. 99.99999% of people in the world have never had polio in the last 40, 50 years, right? Most people don't even know polio ever existed. Most people probably have never heard of polio, because polio, for all intents and purposes, has been eradicated. Why
it's
has
back.
polio been eradicated, Jonathan?
Except
because
it's back.
so many people got the vaccine, right?
That's
so many
correct.
people got vaccinated
Yeah.
for the polio vaccine that there was no host to transfer the vaccine to somebody else, right?
Except
And
it's back.
to Dr. Hudson's point, polio is back. Polio is back because there are so many anti-vaxxers who don't want to get the polio vaccine. And so
Yep.
now there are hosts that the virus can go into and replicate in, who can then pass it on to other people who don't want to get vaccinated, and who can pass it on to other people who don't get vaccinated. The point is, the more of us who get vaccinated, the more likely it is for all of us to essentially eradicate a virus. The flu vaccine perpetuates itself because a significant number of people do not get vaccinated with the flu. If everybody got vaccinated with the flu,
it also mutates.
Go ahead.
That's the problem. The thing is that it's not stable, and that's the difference with COVID, is that it is a little bit more stable. It has a replication editor that reduces the amount of mutations, because if you'll remember, when the virus infects your cells, it takes over your machinery to make more of its particles.
Yep.
So essentially what that means is that in that cell, instead of that cell producing proteins and sending signals related to your genetic code, it turns off what it's supposed to be doing for you and starts working for the virus. Mm-hmm. And so that's a big part of this whole mutation conversation, because what happens is that you start replicating the virus's transcript, and there's errors that happen there, and because it's just because of error. And so when that happens, that's how mutations accumulate over time. And that's why, for example, with HIV, between it mutating so rapidly within each host, and then also finding ways to evade the immune system within cells, that's why it's so hard to find a cure and a vaccine for that, because it's very stealth. It's a stealth commander type of thing. It's like that. It's like Bond's ultimate foe. You feel me? Like it's Thanos. You feel me? Like we can't figure that out yet. And then when you think about the flu vaccine, it definitely has a higher propensity to mutate, probably somewhere in between HIV and COVID. And that's why we, every season have to continually meet that challenge of trying to find a new vaccine, because there's a new strain. And what I want to say about that with COVID is that we are seeing, even now, little pockets of mutation in Texas. We're seeing this new strain out of the UK, and is it South Africa or the other place? And now in Canada, we're seeing the UK strain in Canada now. So it's only going to be a matter of time. And that's the other sort of point, is that even though viruses mutate a lot, this one in particular is a little more stable. So, and that spike protein is a little more conserved, right? So it's like, so even though it is mutating and we're seeing little variant strains popping up here and there, the vaccines that we have that are rolling out now, and more than likely the ones that are on the back burner are still in the clinical phases, are predicted to have good coverage in spite of that natural level of mutation that we see for this particular virus. But to me, because of the seeming impossibility of getting anyone in the world to care about that neighbor or that person that you take care of or whoever, and not doing whatever you can to keep others from getting the virus, that is an ineffective message program. It is not working. People either don't care about other people or they don't care about other people. You feel me? And so it's like, I'm so thankful that we are in an era where we have such rapid vaccine development platforms where we can get something real quick to the market, because y'all can't sit down and do what you're supposed to do. I don't see any of you wearing your mask right, always hanging off the nose, never, ever doing it in the club, on the airplane, it's a wrap. If we had to wait for humanity to do the right thing, we would all perish. So the fact that we have the vaccine, to me, that's like a life raft. Y'all better go get in it. Because you're not doing what you're supposed to do to prevent yourself from getting the disease, as we can see. We're dying at 3 times the rate. We have higher infectivity. Obviously, a lot of that has to do with our susceptibility and the risk with the cardiovascular disease, as we discussed. But from what I'm seeing in my community, that also has a lot to do with people refusing to do what the CDC has recommended. A lot of that has to do with the disinformation and propaganda from our administration and their bungling of the virus response. All of that works together. It's all in that same package, right? But for us, the vaccine is a godsend, because y'all not gonna do right. Go get it. Because I know you're not gonna wear your mask right. You know you're not gonna put it open your nose. I know you're still gonna go to your friend's house. You're still gonna do whatever you wanna do. You're going to the club, hanging out. I see people in the bar right down the street is like every weekend it looks like Freaknik. You feel me? There's no way they're all wearing their mask in the bar. They're eating, they're drinking. Get out of here. Go get the vaccine.
And I think that's something that we have to bring up, because you're saying, you're not doing what you're supposed to do, and you're right. But I think there's something that I hope that's something that we could drive home, and that people listening to this do, is I hope they take us seriously. I mean, I know I'm not a physician. I said what my background is, but you're Dr. Hudson, you have a PhD, a real fancy one. I don't even remember what it's in. I just know you're over my head now. And we all know Jonathan is, he's just over the top smart. We're all.
Can I just say course 7 for life? Can I say that?
We're course 7 for life, and I still have my shirt. Y'all see, I have
for real.
Love it.
But one thing that I do talk about it at work, and it's one of those times where it's a joke, but it's kind of not funny. But I would say to some of the doctors that I work with, I would say, these patients, they want to be late for their appointment. They want to be late for their ultrasound, but they're on time for their weave appointment. They're on time for their nail appointment, right? They're, and I'm saying that because I think that it's almost like people would rather get their information from those sources. They'd rather sit around the barbershop and talk about what they've heard and what they're reading on their phone, or sit in the salon and talk about, oh, well, woody woo, and she did this and she did that, and I heard this and I read it on my phone. I understand that's your community, but they are not giving you accurate information all the time. And I know that it's very hard, for all the things we talked about, it's very hard to put your faith in the medical community. And I know that we're dealing with a lot of history. I mean, I didn't even read y'all a third of my thesis. I didn't even, trust me. But I just really, I'm very passionate about this. Google is not, again, as one of my coworkers says, your Google search does not replace my medical degree. We need to listen to the science. And if you want to talk to your friends, that's fine, but your friends are not your doctor. Your friend, your beautician, your nail technician is not your doctor. So we as a community.
But I mean, I think the other problem there is that there's so many people who don't have access to care, or equitable care for that matter. I know here in my community, no, there's not access to care the way people need it. And so I get that makes total sense to me, because we're talking about people who use the emergency room as their
they use the emergency room
annual. Yeah, because they don't have a choice.
Yeah.
Period. So there's a lot of that. What we want to do with home medicine, one of the things we want to do is try to supplement the terrible care that everybody gets, and start, to all your points, bringing people around to that awareness. I mean, I think it's a good time to do that, because there's so many Black vegan movements and all this whole eating movements and all this stuff. And it's if we can teach ourselves how to grow food again, and medicinal herbs, and remember the home remedies that we have forgotten because we don't even know our culture. You know what I mean? Like,
Right.
and all the things that have been lost and forgotten. If we can remember some things, then maybe we can raise our own standard of community care.
Mm-hmm.
And like, to your point, like, people will start, you know, taking better care of themselves, doing the things that they know they're supposed to do. All of that starts with messaging. And for us, or at least we think so. And that's why we just felt like like the pandemic for us, I think, made us realize that there is no one that speaks to us. You know what I mean? Like you were saying, like how whatever happens in the larger population. Well, right now, what we're seeing in the larger population is a complete dereliction of duty. You know what I mean? In terms of the pandemic. And so we're all just kind of left flailing, but there's no one to tell people XYZ, this is what the virus is, this is what the vaccine is. Mm-hmm. Obviously, stay at home and wear your mask is not a good enough message. But, you know, for us, I feel like we just want to make sure that people, I mean, I understand what your point is, but I would encourage so many people to use Google. There's so much on the World Wide Web that you can learn, that you don't have to get your information from anyone else. You know what I mean? Like, and that's maybe that's unreasonable for me to presume.
I think
about
some
people,
of it,
but
go ahead.
Yeah, no. I mean, just because, you know, I mean, I think we all have, you know, everything in the world, all the information in the world at our fingertips, but, you know, we don't all know how to access it or even how to interpret it. And I think that's,
it's this discernment. It's being able to discern what's factual and what's not, you know?
I think Jonathan, I think that is kind of where I was going with my point, was that people are getting information, but it's not the right information, but they maybe don't know that it's not the right information. Mm-hmm. And that becomes the issue. But I think to Dr. Hudson's point, I think some of it is also kind of, I would say in some ways regional. And what I mean by that is, and I'll use a work example. So I do telemedicine, and, you know, me being in the Northeast in New Jersey, people really like it. You know, I'm seeing patients and you know, it usually goes well. Now, on the flip side, we had a meeting and we were talking to some counselors who were in the Midwest. And we were asking them, you know, well, how does it work in terms of the telemedicine, in terms of, you know, do the patients always see you on the screen? And one of the Midwest counselors said, you know what, a lot of patients out here don't even have good internet. So it's always phone consult. To do pediment. And I didn't even think about that because I'm so used to being, you know, in New Jersey, New York, what are you talking about? Everyone's on their smartphone. People don't even, you know, look at each other, but it's different in different parts of the country. I think people access information differently. So to Dr. Hudson's point, they may be getting their information a different way than maybe what I may be used to, or what other people may be used to. So I think part of our goal here is to kind of make sure that everybody is getting access to good information.
Yeah, and you know, it's interesting you mentioned that, because we seldom realize how interconnected issues are, right? Because the issue that you point out in the Midwest is not necessarily a medical issue, right? But it impacts people's healthcare, right? Whether or not people in rural areas can have access to quality internet is an issue that affects health. Whether or not people in New York can have access to quality food impacts their health, right? And so those are political issues, right? Those are often political and sometimes commercial, you know, business issues, but they completely are intertwined with health discussions everywhere. And so like for me, like my goal is to handle policy for hood medicine, right? So for me, I'm looking at this like this is a political question. These are, you know, why do we not have high-speed internet access all across this country? right?
Mhm.
And if we don't have an administration who sets that as a goal, then ultimately what they're not considering, they may be thinking, oh, great internet access means kids can play video games and people can stream movies and whatnot. But no, great internet access means during a pandemic, a 90-year-old woman who suffers from heart disease and is having pains in her chest can call her doctor, and her doctor can talk to her and look at her and have a conversation with her and see what that problem is and suggest, hey, maybe you need to go to the emergency room, or maybe you need some Mylanta.
Right.
And if you can't have access to quality internet, you can't get those things done. So we have to realize that health care is such a much broader discussion than just whether or not you can go to the doctor's office. It's also whether or not you can be seen by your doctor if you're in an area that doesn't have good internet access, or if you can get some quality nutritious food, or you have a food desert in the area you live in.
Yeah. And it's not just technological access. We're talking about transportation too.
Yep.
People not being able to make it to the grocery store that's like however many miles away from their community because they don't have a vehicle, or to the doctor or anything else.
Right.
So yeah.
And it's interesting that we do this talk today on the second day of Kwanzaa, which is Kujichagulia, self-determination, right? Because, and I was sort of circling back to some of the things that we talked about today, right? We want you to be self-sufficient. We want our community to take self-care, seriously. We don't want you to avoid going to see doctors, but we want you to be able to be healthy enough where when you make those visits to your doctors, you don't have to rely on them for your personal care because you've already done enough to take care of yourself. So Kujichagulia means self-determination. We want you to do everything possible, grow your own foods, eat healthy, have access to quality foods, have access to good health care, so that you can do the preventative things so you don't end up on an operating table. You don't end up in a position where a doctor who may be biased as far as palliative care is concerned doesn't treat you appropriately because he doesn't think you need the care that you absolutely do need. So let's do all these other things. Let's do all the things within our own power to prevent you from being in a situation where somebody's bias may lead to your death. All right, let's do those things.
Yeah. And I think I really see the movement popping up everywhere. It makes me so excited. Like, I have a friend that's in like Nashville, and he has like a whole sort of compound in a way where like it's like a retreat where Black people can go and get like PTSD care. Like obviously all of these things that we've discussed and more, because this is focused solely on the health system and the medical realm. But there's so many other things. There are so many other ways that we experience violence against our bodies and prejudice within our government and systems in this society. And it's to me, it's like everybody's like all like buzzword mental health and everything, and it's just like I don't understand how anyone could really claim to be a mental health advocate, and we're going to deny and excuse like centuries of trauma and just make it seem like we need to just get over it already. I thought you guys cared about mental health though, because that's one of the biggest issues, period, that we have. Trauma. You know what I mean? So it's like there's like little groups cropping up here and there that are trying to address Black people's mental health and physical health in terms of like, like there's even like self-defense courses and things for Black women that are going on all over the country, and healthy food groups and stuff like that. And so I really feel like it's a good time to kind of try to catch that momentum and encourage people to look at their health in a different way, you know.
Well, I wanted to just piggyback on something that Jonathan said, and in terms of kind of bringing it back to what we were talking about earlier. You know, a lot of the times, the way that you recuperate from a health event, how quickly and how well you recuperate depends on your baseline going into the health event. And most of the data that I've read has said that, you know, regardless of age, the people who do not have underlying conditions, right, tend to do better than the people who did. I mean, obviously age is a factor, but you know, it's important. I mean, there was a case of a woman in China, which actually kind of made me chuckle. She was 102 years old and she recovered from coronavirus. And, but the doctor said, like, this is just one of those old women who's just old. Like that was her only underlying condition. She didn't have, no, I mean, seriously. And as a joke to celebrate, they gave her a Corona to drink because they were like, you made it, have a Corona. But all jokes aside, I mean, you know, so that the preventive piece is important, but not just the physical, but to the point that you two were making, also the mental, because what we're seeing during quarantine is we've been seeing a lot of rates of depression and anxiety increase. You know, people's stress is through the roof. And when you
and then the Black Lives Matter uprising over the summer,
correct,
I mean, we're just constantly bombarded with these images.
Correct. And
with this knowledge.
Right. And you're home, you're on quarantine. So what are you doing? Well, you may not be working. So you're just bombarded with the visuals on CNN and wherever of this unrest. And so it's leading to the mental health piece, the stress piece. And we also know stress can affect you, you know, physically. So, you know, we have to look at all those parts and we also have to take care of each other. And this is kind of also a funny story that I'll add, but during quarantine, and Dr. Hudson, you're going to laugh at this because this is how I got in touch with you. During quarantine, I discovered Facebook video chat. Didn't know it existed. I found it by accident. I was trying to message some people and I have been Facebook chatting with people, you know, through quarantine, and people they laugh at me. They're like, what are you doing? And I said, but not for nothing. I'm checking on you because not everybody's handling this well. And everybody has said to me, Jennifer, it's so important, you know, that you're doing that because, you know, we need to make sure that we're okay as a community. And I have to say that when I called Dr. Hudson, I think she was surprised, right? but it was important. But it was important. It was important too. And I think that, you know, we have to check on each other. You know, we really do. And even if it's just to say, look, are you okay? That's an important
Annie,
question.
are you okay? You feel me?
Are you okay? Like for real, you know, like how are you? You know, and that's something important that we need to do. It really is.
No, we really do. Yeah, and we also had talked about doing. We're kind of like trying to conceive of what it would look like, but we think it's important to honor those that we've lost too. I mean, I think we only ever. First of all, half of the country denies that the virus is even going on, but then at the same time calls it the China virus. So I don't understand. There's a lot of
or standing in line for vaccinations for a virus that they didn't believe existed.
Right.
Well, the best,
but like for those
well,
people,
the best is when they've been diagnosed. The best is, you know, I've had coworkers who have said that like the patient is in the hospital and the doctor's telling them you have coronavirus and they're like, but that doesn't exist. And the doctor's like, well, then what's killing you? Like, you know, so
it's like, you know, for all those people who don't care and think it's a hoax, you know, there's also an entire contingent of people whose numbers grow by the day, who have lost someone that they didn't get to spend their last moments with, they didn't get to bury properly, probably still sitting in a refrigerated truck right now somewhere in a parking lot. You feel me? And we need to find a way to honor that. Like, I feel like we see the statistics, we know that we're dying at 3 times the rate of everybody else, but we live under an administration that prioritizes the economy over everything else, and for certain has done everything, you know, to ensure that there is, you know, no competent response. And that includes acknowledging the grief of millions. You feel me? We've lost
Neecey,
like almost 500,000 people. Ain't nobody even talking about it.
My mom is 72 years old, and I've been blessed to see her every summer in June. She'll come up and spend some time with my kids before going home to Barbados to spend some time with our extended family, her sisters and brother. And this is the first time in a while I haven't seen her, you know, over the summer. And I'd hoped to make a trip down to Atlanta to see her for Thanksgiving, and I wasn't able to. My mom is 72 years old. She's been through a very long, difficult life. She has been stressed. She's had injuries. She's had health problems. God willing, she makes it to another June where she can come and visit me. But if and something happens to her, over, you know, because of coronavirus and because people just couldn't sit their behinds down so we can get through this, I can't tell you the level of anger I will have at the world. I can't tell you. I can't even, you know, like, there are people out there who did not get to say goodbye to their parents.
Yep.
They did not get to say goodbye. There are people out there who didn't know their parents were even dead for weeks.
Yeah.
Right? Because this pandemic is real and is serious. And until we get, you know, the overwhelming majority of people in this country to start taking it as seriously as it really is, I'm not going to be able to see my mom. And God forbid something happens to her in the time period between now and whenever that is. Like, I will be crushed as I'm sure other people are. So to your point, man, we have to do the right thing, and we have to do it now, because people like me want to be around their family members and not have to worry about infecting them, or them getting sick, or getting their your children sick. Like, we got to do the right thing. We got to take care of this and get rid of this thing as soon as possible.
And we're still hovering around like 13% of the population, but we dying at 3 times the rate. Like, what we're trying to do is stop us from going extinct. And if it's like, if you're not going to listen, go get vaccinated. Yeah. Please. Sorry, Jennifer.
Well, I was just going to say that, you know, I guess just with seeing just the way everything has gone on, it's really made me kind of think about, you know, what am I going to do going forward? And what I mean by that is, you know, I fully intend to get the vaccine. You know, I've already told my family members, like, look, when I don't know where I am in the totem pole, I don't know if I'm going to get it through my doctor's office or through my job. Again, being, you know, in the medical field, when the phone call comes, I will be there. But I still don't think it ends there. I still think I will wear a mask. I still think I will wear a mask. Just, you know,
You must. Thank you for bringing that point up.
No, but that's what I'm saying, because I think there are people who think that, oh, I get the vaccine, I'm good. I can go to the club, you know, and like, that's not really, I think, how this works. Like, even once I get the vaccine, I will still continue to wear a mask. I'm still going to, you know, be cautious. Now, I think that there are some things that we all always kind of did, right? Like, I think we all always were kind of leery in a public bathroom. Well, I was, you know, like, I never opened the knob with my hand, but I'm just saying it's kind of making ever, right? That was before COVID. But I think that, you know, I will still continue to really kind of, you know, look at how I do things, you know, and I think that we need to just, you know, change what we do. But at the same time, it's also kind of made me think, like, God, what were we doing before? Like, I kind of think about just
what were we doing
how
before?
we were in the dorm and at parties and just in people's faces. And I just kind of think
this
like,
whole year, like, knock on wood, none of us have been sick this whole year. And it just made me really stop and realize, oh my God, people have been blowing their snot in my face for decades. Like, if I think about how many times I catch a cold during the year, usually with 2 kids in school and like from just work, and I'm just like, just isolating and wearing a mask. I have not been sick since like last November.
Yeah.
Knock on wood, because they're so effective. That is the point. And to your point, please don't think, like we've all been saying this whole time, that the vaccine is the cure-all or this ultimate prophylactic. You still need to wear a mask. You still need to socially distance and isolate. I don't expect you to do that because you're not doing it now. The vaccination will help. But at the same time, you know, for us, in terms of like, definitely, let's, you know, reiterate, there's 2 doses. So you have to go back and get both if you want to have that lasting protection over time. But for us, it's just so important that we not only mobilize people to go get the vaccine, but also, to your point, drive home the fact that it's not over. Because in terms of what it looks like when it starts to be over and the herd immunity that we keep hearing about, that means that almost like 75 to 85-ish% of our population needs to get vaccinated. Why? Because as we can see right now, when no one is vaccinated, you know, if we're all in a herd or a crowd together and 1 or 2 people is infected, then none of us in that herd or that crowd will be protected from infection. You know, the masks help, you know, social distancing helps, but ultimately, because of the way the particles move, because of how long they linger in the air, because of how we're not doing the masks right or standing far enough apart from each other, that we can't get it in our head that we need to make that distance, even though it's outside of our nature. You know, because of all those things, right now, as we can see, the whole map is red. If you pull up that world map right now, the whole world is red.
Listen,
because
Jersey,
nobody's been vaccinated. But once everybody starts to get vaccinated, then when you're in that same group or that same herd and you're out in a crowd, if there's 1 or 2 infected people in that crowd and the majority of that crowd has been vaccinated, then the virus is going to have a harder time spreading around the people in that crowd, because it's about proximity and how close you're standing to someone, whether or not they have the mask on, whether or not like you're doing what you're supposed to do to prevent those breath droplets from getting into your eyes, nose, and mouth. So yeah, Jonathan, please go.
Well, I was going to say, you know, for the majority of the past year, New Jersey, New York, and Connecticut have been like the pinnacle of management of COVID, right? We were seeing like 3% rates here in New Jersey for a while. Now we're at like 12% in New Jersey. You know, New York is at 6% or something like that. Connecticut is, I think, at 7 or 8%. You know,
something like that.
Yeah, even in the states that had done a tremendous job of trying to quell the, you know, the rate increases in COVID cases, right now in December of 2020, we're a do not visit state. You know, that's crazy.
We are.
We're a do not visit state.
So are we. Not just because of COVID though, but also because of the Green Book. But yeah, so are we. Yeah.
So, you know, so the point is, we all have a responsibility and we all have to do the right thing. And if we don't, then we're not going to get out of this. And to my point earlier about the polio vaccine and how it's essentially been eradicated, you know, and to the flu that often, you know, replicates and changes and whatnot, the more people who get the vaccine, the fewer hosts we have for these viruses to replicate and change in, right? And we won't have different versions of the virus if we all get vaccinated, and the viruses don't have a place to replicate and change.
Come
if
on,
they can't
Jonathan.
take control of your If they can't take control of the machinery in your body that creates, DNA and RNA, then they can't have anything to use to change and to send out different viruses out here to get people even more sick. All of us can take care of our neighbors, our friends, and our family by just doing something very simple, getting the vaccine.
And I think if I can just piggyback on what Jonathan is saying, really just in just the most direct layman terms I can ever give you. And I'm known as the directive counselor, by the way, on my job. But I mean, the bottom line is the virus needs a host, and the virus likes crowds. This really isn't that complex.
It's about proximity. Period.
It needs a host, and it likes crowds. End of discussion. So,
period.
If you avoid crowds and you don't give it a host, it'll go away. We can stop it.
The virus is like a college freshman. It's looking for a party. That's all it's looking for.
Hey.
Wow.
It's looking for a party.
Wow. Wow. Okay.
That's one of those hood medicine realities, right?
Oh,
hey.
Wow. Okay.
Hey.
Okay. You took it there, but I'm okay with it, though. I'm okay with it.
I think we've all seen a great many parties in our lifetime. Yeah, I mean, yes, I really am so glad that you got a chance to come on with us tonight, because I just feel like there's so many things. I learned so many things, first of all, and I'm really appreciative. I really appreciate that you took the time to come talk to us about this, because I think it's so important that people have trusted messengers, you know what I mean? And part of the only sort of way that we can try to combat all of the propaganda and disinformation and all of the noise is to try to be our human selves and connect with people and show that we care. Because I think people are more open when they know that you care, and which is, to me, the number one problem in medicine right now is how many physicians abuse their trust. Yes, the trust. Thank you. Yep. And so I'm really grateful that you came on and that we had the chance to talk about all this. And I hope that you'll come back someday.
But just one thing I do want to say, in all fairness, there are a lot of physicians who really are going above and beyond and are doing their job with little to no help or resources.
Certainly, yeah.
And I just want to make sure that we're giving credit where credit is due.
Yes, you're right. I mean, this is certainly not just like a physician bashing session. However,
of course not.
It's totally important that we bring to light people's very real and well-earned stigma, from what's been going on over the past 500 years. So yeah, but I think that's a good point, because there are people, white guys, who care and want people to live and lead healthy lives and stay alive. That's what we want for our whole mission is to come alongside and try to save Black and brown lives in any way that we can.
Yep.
So, Jonathan, did you want to close?
I just want to say thank you again, Jennifer. We've all known each other for since 1996.
Don't say it out loud.
Yeah. So it's amazing.
I'm the oldest, so
she's the big sister.
You are. So this is really kind of full circle for the three of us, because we met at a very early age in an environment that was difficult, to put it lightly. We all survived that environment, and now we're all here trying to make sure that people survive, this crazy environment that we all find ourselves in now. So thank you, Jennifer, for all your expertise, all of the information you were able to share with us. Dr. Hudson, your very real lived experience matters, and we have to make sure people understand that, you know, there are very real lived experiences in our communities that are affecting the way we look at and interpret all the information that's being sent to us. But at the same time, we have a responsibility to each other. And if we don't take that responsibility to each other, nobody else is going to take that responsibility for us. So I'm looking forward to the impact that this chat will have, and that everything that this organization will do to help people understand their responsibility and do the right thing.
Thank you. Thank you guys so much, both of you. And thank you everyone for joining us tonight.
God bless
Have
you
a good
guys.
evening.